I'm just going to talk a little bit about some cases, my data for your opinion, and show you my experience with this stuff. So, in full disclosure, is there right there? There we go, thank you. Well, you know, it's not advancing on the computer, but it is advancing up there. So I do consulting with industry, including doing some stuff with CarboFix, do some committee work. You've seen this. I think the main selling point, as Dave pointed out, is that the modulus of elasticity is somewhere closer to bone, and the closer you can get to bone, I think the more bone likes it. You can see they've done fatigue tests. As you would expect, you know, carbon fiber is being used everywhere, from cars to airplanes, and it's mostly desired because of this fatigue property it has. So it's almost infatigable in certain configurations. And the technology that they've developed in Israel is how to specifically layer the fibers into the PEEK and then put it together so that you can actually adjust which direction the flexural modulus occurs. So you can have one set be flexible in bending but not torsion, and you can lay the fibers in a different way. You can be flexible in torsion but not bending. So you can actually modulate this for the implant to make it specific for the bone you want. And you can see here examples of CT and MR artifacts, metal compared to carbon fiber. You can actually see it. The oncologists love this because when they do proton beam therapy, you don't get any scatter. In trauma, how many times have we done a retrograde femoral nail and you have a ligament injury, you get the MRI and the radiology says inconclusive exam because of metal artifacts. So I'll show you cases where you can actually see the ACL, PCL quite nicely, and I think that's one big advantage in the trauma world. So the big question is, if you can't see the implant, right, how do you do the interlocking screws? Everyone asks that. You know, we use perfect circles. That's what we all grew up with, right? You get the two circles and you put the drill in. You've got the dark nail in the circle there. You know when your drill's in the hole and so forth. So what they've done is they've put radiolucent tantalum markers along the nail to identify the top of the nail, the holes, and the length of the nail and the plate. So it's just basically a shape identifier. And when it comes to the holes, at first I thought, when they came and showed this to me, I'm like, oh man, this is going to be hard. There's no way I can do this. People aren't going to be able to do this. If I can't do it, no one else can do it either. I mean, this is horrible. And in actuality, it's quite easy, and I'll show you why. What they do is they put 2 markers around each hole, which basically gives you 4 markers per hole. And when you look at it in an orthogonal fashion, you have 4 markers. If you look at it in a direct end-on parallel fashion, those 4 markers now become 2 dots. And when you get those 2 dots, now you have your equivalent of a perfect circle. And you can see that it starts off, you can either rotate the nail or the leg, or you can rotate the C-arm to match it. I use a C-arm. I hold the leg steady and then kind of take my first guess based on the jig. And within 2 or 3 iterations, you've got it. I dim the lights a little bit. You increase the KV sometimes if you have an obese patient. And then when you get to those 2 dots right there, you can see that you can actually see a faint outline of the circle itself a lot of times. But you see those 2 dots basically tell you that you're now looking right through the interlocking hole, and your drill goes right through, and you can actually feel it. So if you hit the nail, you're going to have that resistance just like you would if you hit a metal nail. And the key is, don't keep pushing, because if you're hitting the nail, you can drill through the nail, and you don't want to do that. So you want to back it off and put the tip of the nail of the drill bit between those 2 dots. And you can see this is what happens if you rotate, and boom, you've got your 2 dots, you've got your circle, and you can get your interlocks. This is what it looks like in real life. You can see the drill between those 2 dots. If you're in a dynamic hole, obviously you're going to have more play than if a static hole. And you can see the 4 dots up above are 90 degrees. That represents the interlocking hole just above that nail, where if you came orthogonal to that, that would turn into 2 dots as well. So that I don't belabor the point, you're going to see the science presented by Alex. I'm just going to go from top to bottom, some of the cases we've done. Here's a humeral nail. I'm not so dogmatic that the trauma surgeons think you have to plate every humerus because the results are better, and if you nail a humerus, you're going to have horrible results. Truth is, they both work. Done properly, they're both going to work fine, and I think especially in osteoporotic bone, a nail is probably a better way of treating a humerus fracture than somebody who needs it to weight bear. I'd be a little bit uncomfortable putting a plate on a humerus in a very osteoporotic bone. And it's a pretty simple system. You know, it's a tube and you put a rod through it. The only thing with the humeral nail, it's not cannulated. You don't really need the cannulation. It's pretty easy to get it down. You can visualize the tip of the nail going in. One of the things I learned from Mike Chapman when you do humeral nailing is I always make a little incision over the fracture site, stick my finger in there to make sure that that radial nerve doesn't get wound up with the reamer or with the nail going in. So, and the reason being is that when I was a fellow, we had 2 cases where the radial nerve was referred to him entrapped in the fracture from nailing. So it's just one of those technique pearls, I think, that makes sense, and it's got very low morbidity. And you can see how a pathologic fracture like this, you can actually start seeing the callus and it starts to form. And I guess the best way to describe it, I can't prove it scientifically. I've talked to a radiologist about ways of doing it. The best way to describe it is better callus faster. So think about that, better callus faster. So you get more robust callus probably because of the flexural modulus of the nail, and it happens quicker because as a patient uses it, the bone healing cascade is probably accelerated because you have less stress shielding. You could measure it with a CT scan, but doing a study where you're getting serial CTs on somebody every week is probably not going to make it through the IRB. And maybe one day they'll have a radiographic ability to actually measure the calcium density of the callus, which I think would probably prove that. This is somebody where this guy unfortunately had an industrial injury, open fracture on one side, a elbow amputation on the other side with a humerus fracture, had to quickly fix him to get him through that. And then we came back since we needed to get him moving and active very quickly. We went ahead and put a nail in him, and he actually went on to heal quite quickly and did quite well despite the fact that he was missing his hand. Another one where you had, this is a teacher. Normally you would probably treat these individual fractures without surgery. So the isolated humerus you probably wouldn't treat with surgery, and the proximal humerus I think in the elderly you may or may not treat with surgery, especially one like this. But in a lady like this who's going to have 2 arms tied up, you can ask yourself, you know, how do you clean yourself, you know, if you don't have some use of your arms. So we went ahead and fixed them. We rotted the humerus, let her weight bear through that. We plated the other side. I've changed how I do proximal humerus post-operatively. Our shoulder guys have taught me a lot, the shoulder specialists. You know, the key is all about the tuberosities in the cuff. So it's not about the bone, it's about the soft tissues, as is most fractures right now. So we keep them down for about a month before we get them moving, because you can always get your motion back, but you can't always get your cuff and your tuberosities back. Another one, this is a lady who had a remote cuff repair, ground level fall. Again, needed to get fixed, and we went ahead and put the plate on. And you can see same thing Dave does. Basically, we try to get it out of varus. And now calcar screw is very important to help support the head, and they go on to heal fairly nicely. So and again, you see this callus that you normally don't see, because I think you're getting it's flexible but stable, another way to describe it, because you get the flexion and you get the bone motion and the micromotion, but you get stability because you have an implant that doesn't fatigue. Lower extremity, this is a bilateral femur fracture in a young kid. You would expect this to heal pretty quickly, but still, you don't usually see callus at 2 weeks, and usually the x-rays lag behind what's really happening, so this kid probably healed much quicker than the usual 8 weeks you would expect in a femur fracture in somebody that young. And in 12 weeks, you see a fairly robust callus, and actually you see how smooth the edges are. So to me, I kind of think of this is probably more typical of what you'd see around 4 or 5 months with metal, with the remodeling that occurs. So again, can't prove it. It's just one of those things where, you know, as you look at hundreds and hundreds of x-rays, you kind of get the gestalt of what's happening, and I think it's just better callus faster. Here's a guy, first time we actually ended up doing an MR, you'll see why, because he fell from a truck, no big deal. We put a retrograde nail on them. Had knee pain instability. We had to get the MRI on them, and this is what the MRs look like. So you don't see an MR result like this with metal. And I think in the trauma field, especially in the femur and the tibia, the biggest advantage is you have, what, 15–20% of people are going to have a knee soft tissue lesion. So when you do get that MR, you're not getting the radiology results saying inconclusive clinical correlation required. You can actually, the radiologist called me up, this is the first time we did it. He goes, what the hell are you putting in those femurs? I can actually see this now. Is that a rod? Is that, what is that? And they're fascinated by this. And so they love this stuff. And so he called me back up and said, yeah, man, I can tell you, what the lesion is, and I can actually read it. You can see the ACL, you can see the PCL, you can see the menisci, you can actually have a legitimate MRI read. And then he went on to heal, and his big problem actually was he developed heterotopic bone up above that we had to take care of. Another one, 55-year-old with a femur fracture. Doing some of our tricks, we pass the guide wire. The one thing you do with this that's different is those of us who've been around long enough, remembering the exchange, the chest tubes, where you had to put the ball tip, you put the chest tube in, then you put the non-ball tip in. The nail technology evolved where now the diameter allowed you to not have to do the exchange. With this particular technique, you use the ball tip to ream, and then you put a chest tube in and you put a nitinol wire in, which allows you to have the guidance for the nail because the inner diameter of the nail is smaller, and I think you need that because it's not metal. So you have increased strength to maintain the fatigue and the strength of the nail. So you have to exchange the rod, and that's what you do. You can see the nitinol nail that the rod guide wire that goes in, and then you put the rod in. So again, knee instability, and you can see this person. You can actually see the tear of the ACL, the PCL, and you can see the menisci pretty well. And again, you wouldn't be able to have this kind of an image with metal. So I think my favorite part of this whole system is the femoral parts. So love the femoral nail and the hip nail for this very reason. Here's a distal femur. I think Alex is going to really dive into the science of this and showing you some comparative stuff. But again, it's the same technique we use for metal. This implant is looks and behaves and feels very similar to what we currently have. I think one of the things that we've learned with metal is you can modulate the construct stiffness, even though you can't change the metal stiffness. We modulate the construct stiffness by where we place the screws. So not putting locking screws close to the fracture, using non-locking screws to help reduce the fracture, and then plating long and keeping your screws far away so that you have the stability you need, but you also have the flexion in the metal. The only problem is with metal, again, it's a race between biology and metallurgy, and if you have a compromised soft tissue envelope for whatever reason, the metallurgy may lose and you get a fatigue fracture, whereas if with the carbon fiber, it buys you more time. So if you have the open fracture, if you have a diabetic, you're going to be able to get more time to allow that biology to catch up with it. And you can see that medial callus is what you're always hoping for. So you put this in, and as soon as you see that medial callus, you know you're probably going to be okay. It's when you don't see that medial callus that you start worrying, and and the clock starts to tick. Here's a couple tricks for the proximal femur. You put the nail in, and this happens with metal too, so I'm just kind of showing you some of the experiences we have. You put the nail in, and you can kind of see it on that one. You see the little tips going in as the nail enters, and how many times have you guys had that basi-cervical fracture? You put the nail in, and it's a perfect reduction before the nail goes in. You put the nail in, and it separates and goes in the varus. And a lot of times it's because of the soft tissue envelope pushing out lateralizing the nail, separating it. And so one of the tricks I do is I make a little incision, anterolateral window, go between the vastus and then the femur. You come right along the anterior neck and you get a cob and you just lever it in. You can use a hook, you can use a cob, you can use whatever implant you want. You just lock that femoral medial side in, and this is the key for the fractures, is you don't want the neck to be medial to the shaft, because that's the kiss of death for a lot of these, because it just keeps sliding and sliding and sliding. So some of the older folks here might remember the Demon Houston osteotomy, where you'd actually put it in valgus and put 150-degree DHS in. So you'd medialize a shaft to basically get the shaft under the neck. What you're doing here is you're getting the neck into the shaft so that you have that calcar restored. And this is just one of the tricks to do. And then you go ahead, you put the screws, and you can see from the left to the right, you can actually compress it and squeeze that fracture down on the table and see that bone-on-bone contact. And Frankel and Bernstein, way back when, did biomechanics studies showing that if you can get bone-to-bone contact, that's 75% of your construct stability. So that you're not depending on your implant. It becomes a load-sharing construct, not a load-bearing construct. You can see they went on to heal here. They have a short version and a long version in this, just like other companies. This is one tougher case, a lady who had a lot of injuries, obese, a lot of other issues going on. But this is one of the tough cases where it's sort of challenging. I think the book answer for this is a retrograde nail with a DHS up above. Because of the logistics and some of the setup issues, that was less likely, and so our choice given to us was try to do this with one implant, which is doable, albeit not advisable and not easy. We went ahead and pulled the bag of tricks out, reduced it, held it together, and you see the cob there. You see the other thing, we publish a technique where what you do is when you have a fracture that exits through the greater trochanter, when you go to do the reaming, you're going to selectively ream the lateral part, and you're going to lateralize the nail, and the neck is just going to sit there. So when you put the nail in, your nail is actually going to be sitting lateral to where it should be relative to the neck. And what we did is we realized if you take a concave retractor like a Richardson or an appendiceal, you put that onto the reamer, and that captures the reamer shaft so it doesn't slip off, and then you medialize the reaming, and you just take it back and forth like a drill bit or a milling machine, and you end up basically pushing the reamer and creating the path of where the nail should sit on the neck, so that when you put the nail in, it's going to be in the normal anatomic position it should be, as opposed to just pushing everything out laterally. So we medialized it here. We put a clamp on for the proximal portion, held everything together, got the nail in. You can see there's some distraction going on, and then we start compressing it. So we initiate the compression. You can see mid-compression, and you keep squeezing it, and then you get that nice reduction, and it makes you feel pretty good. But then you go down distal, and you're like, oh, geez, look what happened here. So now you got to pull out more bags of tricks. So to put the polar pin in, and you see the nail coming down, and you can see the nail. I don't know if you guys can see it, but these dots represent the advancement of the nail, and that's why I turned the light down and increased the KVP a little bit. That's sort of the trick that they told us to help visualize the contrast a little better. You see as the nail goes down, it's going to hit the polar screw and pin, and then it sort of self-aligns and gets reduced nicely. And then she went up, she actually went on to heal. Here's an interesting case. One of our mountain men, guy had this fracture, looks pretty benign. I think most of us would probably say you could treat this closed. He says, but doc, I'm going to walk on it. I'm like, no, you shouldn't walk on it, man. It's not good. Well, I'm going to walk on it. Don't hurt. He's neuropathic. And he just does what he wants. It's very common down in the South. People do what they want. They don't listen to the doc. So he comes back, still doesn't hurt, doc. I'm like, yeah, but you shouldn't be walking on it, It's starting to fall apart. He goes, but it don't hurt, doc. I'm like, all right, come on back and see me in a month. Don't walk on it. Comes back, he doesn't come back in a month. Comes back in 4 months, says, doc, it don't hurt, but it don't quite look right. I'm like, yeah, it's not right. You're right, it's not right. He's walking on the outside of his foot. So I said, listen, I'm going to have to cut your leg off. You're a douchebag. You're not listening to me. You're not going to have a good result. And I put the fear of God in him. He begged me. He goes, please, doc, just give me one more shot. I promise I'll be a good patient, right? And so we went ahead and used this nail and did a hindfoot fusion on him. Did it all in one thing, fused them together, put some graft in there. Said, okay, doc, I'm going to listen. And he actually turned out, after this, it was like a turning point in his life. It's like the light bulb went off. And all of a sudden, he became a really nice, compliant patient. Said, doc, I appreciate it. I'm going to do everything you say. I didn't walk on it. He's my witness. He was living with some guy. And he said, no, he really hasn't been walking on it. So he stayed off of it for a while, and then we advanced his weight bearing at 6 weeks. You can see the callus forming in 4 months. And I think he healed, and you can actually CT scan this, right? So I didn't CT scan it because I wasn't worried about healing. I just let him walk on it. And I'm like, all right, looks like it's healed. And this is him actually, walking on it now, finally. And so this is one of those, cases where even a blind squirrel finds a nut, got lucky on it. Some unique applications. They still don't make a medial femoral plate, but surprisingly, what's nice is if you take a distal fibula plate or if you take a proximal humeral plate and you put it on the medial side of the femur, it actually fits pretty well. That contour is quite nice. I don't know if any of you guys noticed, the guy who fixed this before fixed a proximal tibia with the old plate, and those of you who recognize it, that's the wrong side. It's actually supposed to go the other way, so use the wrong side plate on this one. He got away with it though, and the guy wasn't complaining about it until he had this femur fracture. So she bulks a lot. That's a 100 pack year bone right there in an 80-year-old. Surprising she lived that long. But we took the plate, turned it upside down, put some lag screws for a split that we found after we opened it, and then just put the plate upside down on the medial side. It's quite a nice fit. It actually just slides right in, and you can get that contour. Sits a little bit obliquely. It's not quite medial, but next time you have one like this, take a proximal humeral plate or a distal fibular plate, the pre-contoured one, and play around with it, and you'll see, wow, it just fits pretty nice in there. So this is what it looks like afterwards. This one, again, visiting family. This is an error of judgment on my part. So they say that chance favors a prepared mind. Not in this case. I wasn't prepared. And, this is one where I learned the hard way. Osteoporotic bone with a distal femur spiral fracture like this. It looks like it's just an extra-articular fracture and it's a chip shot. You're going to put a nail in there, right? And then everything's going to come together. You put a clamp together, hold it together. The truth is, most of these fractures probably have an undisplaced split that goes all the way into the distal section. So if you don't get a CT scan, which I didn't, you wouldn't recognize that. And I didn't recognize it until I got in there. So shame on me for that. When we discovered that, you're already there, you're already open, you got to do something about it. So you're backpedaling, trying to save face and not look like an idiot. And so in this case, what we did, we did nail plate supplementation and went ahead and did a medial plating technique with a lag screw for the distal section, and then went ahead and did the nail for the more diaphyseal component of it. And you can see the polar screws that we used to help with the reduction, and actually went on to do okay. So again, dodged a bullet, my bad. Interesting case here where you had, you can tell when this was done. This is back in the 90s when we used to use these implants and fill every single hole, right? That was sort of the teaching. Every hole had to be filled. I don't think we'd ever do that right now. Even if we use this implant, we wouldn't do that. And it's a very good implant, by the way. The blade plate and the DCS I still think are wonderful implants, and it's a good bailout. Nonetheless, you have a fracture like this, ideally, you're going to want to nail it, right? And if you use metal, a lot of times you would see the circle of the metal and you get lucky. As you put the nail down, the hole of the metal comes in. If you pulled some screws out, you might be able to overlap the plate and the nail together and drop a screw connecting them together. Well, I thought, let's do that. But then I realized I can't see the hole in carbon fiber, because it's not a circle. So you got to see dots. How am I going to see two black dots through a massively white plate? So bit the bullet and took the plate out. And went ahead and did all the usual games we play in the proximal femur, and then put that down, and then you see the nail down there, but now he's got Swiss cheese and bone, and what I didn't realize is when I went to put the interlocking screws in, as luck would have it, you're right through the old holes. So now you've got screws that are just floating around in midair, doing nothing. So what I did is I got lucky, went ahead and pulled it out of the bag of tricks, the old T-plate, the metal T-plate. As it turns out, in a lot of cases, put the drill through the nail, and then took the plate, and I'm playing around with it. I'm like, wow, it just matches those holes perfectly. So we just put that plate, bent it a little bit, and used the plate as a washer in this case. So the plate became a washer where we were able to now transfer the fixation of the nail through the plate into the bone remotely by putting some screws above and below to help stabilize and protect the distal femur, but then still give the interlocking in the axial and the rotational stability of the nail with the interlocking screws by using the plate as a washer connected to the bone. So Frank Liparachi calls this unification using plate nail connections. And I think and Synthes is going to be coming out with a system that actually does this quite nicely in the future where you can do nail plate combinations. Another one, 30-year-old with a bad fracture. That's not supposed to be there. I took that case out. 89-year-old with intertrochanteric fixation that failed. Show you kind of a unique application for this. So this turned out to be somebody who probably had an infection. It was fixed by somebody. The guy said, I think she's infected. Her sed rate is up, her drainage is up, she's got fevers. This lady can't tolerate multiple procedures. So we bit the bullet and said, okay, we're going to do a Prosolac on this. Prosolacs are real expensive. The existing systems that are out there that have prefabricated stuff are very expensive. What I do is I basically make I call this the poor man's Proxilac. You can basically take a hip nail and use that as your rebar. And you know the bulb sucker, the little things that you squeeze, you know, the fluid out, that happens to be just about the size of most acetabulums. And so you take that, the round part off, put a little bit of mineral oil in there. And the reason I do this is because my elective practice is pus, so I do osteomyelitis. And this is stuff that we learned with George Ziran back when he was alive. So basically you take the bulb sucker, you put some mineral oil in there, you take your antibiotic cement with vancomycin, tobramycin, you mix it up in this really loose liquidy state, you pour it all into that bulb sucker, and as it starts to get hard, you take your nail and you shove it in there, and then you let it dry. As it's drying, you take the knife, you peel it off, and now you've got basically this part right here. So you've got the ball part, and then you hand pack cement around the nail, and you get that to fit right into the femur. And we published a couple of case series of this, and the interesting part is she comes back, and I keep telling her, are you ready for your hip to get reimplanted? Every single one of these older people does not want to have an operation. They're like, it doesn't hurt. Why do you want to operate on me? So when they're that old, 80, 90 years old, they're basically going to have a PMMA hemiarthroplasty they'll take to the grave. And then what it does, it treats the infection and gives them some walking function. Here's another one, bad TAD, cut out. And you can see this is what it looked like. She actually had an acetabular defect too, so we just went ahead and put bone cement and did that. And these people aren't candidates for major reconstruction. They probably can't tolerate staged reconstruction because they're sick and they're old. And if they're infected, you just really hose them badly. So it works pretty well. So in summary, I think you've seen some of the biomechanical advantages Dave showed you. These are just some anecdotal clinical cases showing that you can't get this stuff to work. And I think I'm going to hand off the baton to Alex. He's going to actually do a legitimate scientific study showing you a comparison between metal and plastic. Thank you.